So good evening, ladies and gentlemen. Welcome to our first JJ&J Journal Club. We had some success last year in terms of sharing knowledge with our dear colleagues and our medical service community. And once again, this is the beginning of the year, and we really like to kick off with some fires. So today, I would like to show you a case, and that is probably you probably won't see that many throughout the world because the case is relatively rare. So let me just jump straight into it. The case presentation was a 14-year-old male patient. He presented with acute shortness of breath after exertion. Be more specific, he went with his father to the dam for fishing, and then he suddenly felt left-sided chest pain, and he was out of breath. And he did mention that his shortness of breath was progressive in nature, and mom was a nurse working in a close-by hospital and quickly examined him and realized that his heartbeat was actually on the wrong side of the chest. So mom made the diagnosis of dextrocardia and sent it to our local cardiologist. So when he came through, we examined him. He actually had good color, hydration. There's no sign of respiratory distress. There's prominence of his left hemithorax. But clinically, you can palpate his heartbeat in his right hemithorax with no murmur heard. So immediately, we did the investigation. So radiological examination, we did the chest x-ray, barium swallow, echo, and CT scan of his thorax. Now, the x-ray is actually giveaway, but in terms of blood examination, we did his FBC, UNE, LFT, alpha fetal protein, and beta FCG. So that really telling you we worry about some kind of germ cell tumor. This is the chest radiograph that was taken the first day, and immediately you can appreciate that there is a large opacity in the left hemithorax. And within this opacity, you can actually visualize the calcification in the middle. And there is tracheal deviation, and as well as cardiac slowway or mediastinum have shift right across. And then we proceeded to CT scan. And I took a video of it, and then I just want to run through the CT scan with you. Sorry, my hand was shaking when I taken the video, so you can see that is wobbling a little bit. But the important thing is that the CT scan, I'm going to let it run through. So the role of the CT scan is basically to define this opacity, because time to time, some people will say this is a massive pleural effusion. Now, basically, when the mediastinum shifts across to the contralateral hemithorax, it tells you there is a space occupation. And whether that space occupation is due to underlying fluid collection mass or lung or mediastinal mass, we can't define until we did the CT scan. Now, you've seen the CT scan. Basically, there is heterogeneity, there is calcification, and there is mediastinum move across. Now, the important thing about the CT scan, if I can stop somewhere, let me go back up. This is what I meant in terms of calcification. Now, the other things also gave you a fairly important information. It's about the underlying lung. So here, you can't really define the border so well because the mass is massive. And you can see the compression of lung. Let me go up there. You can see a little bit of lung that's atelectatic and compressed by this mass. Now, this mass has also fat density, calcium, and pretty much when I saw the CT scan, I thought this is some kind of teratoma. Okay, now here is a gray vessels that's in the mediastinum. You can see that that's pulmonary artery. But here you my cursor is pointing at an outskirt. You can see some fat density, but the important thing is that you also don't know whether there is any major vascular invasion or not because the compression effect. Then subsequently, this is the other view of the CT scan, and you can appreciate how massive this mass is. You can see capsular, the outer line, and you can see that the opacity in the apex is actually compressed lung. So in that scenario, you can see there's probably a little bit of sliver of lung that's left, but you can see this mass is well encapsulated and pushing the heart right across. So in this, we're basically looking for adjacent organ invasion. So you can see the heart is right there, which is RV, and the pulmonary artery, but no, this is LV, and the aorta going up. You can actually appreciate there is a little bit of fat density in between them, which suggests there is no invasion, but this is only a radiological suspicions. As you continue looking through that, the calcification, we noted that the only thing that we do not see is hair follicles. So then we move on to bear and swallow, because mediastinum have shifted across. Basically, we want to see, are there any adjacent organ invasion? And you can see the bear and swallow goes through quite easily, which this kid does not present with any dysphagia symptoms. And he feels that he was fine. Now, because the nature and the mass, the size of the mass, we realized we could not potentially achieve this resection of the mass at local hospital. So I have contacted Dr. Sussman from Milpark and to ask him to assist in terms of this mass excision. Because if there is any hemodynamic instability, we can easily place this child on ECMO and subsequently support his system. And the various things now the various planning got to do with how do we perform the surgery? Do we go through thoracotomy? Do we go through median sternotomy? And then eventually the decision was being made that we do a trapdoor incision. So trapdoor incision is basically median sternotomy extended into thoracotomy and open up the left side of the chest like a book. So when we got there, the cardiac anesthetist quite quickly induced the patient, and patient was stable throughout. And then he actually did the TOE. So what TOE shows that basically this is LV contracting very well with a little bit of pericardial effusion around it. And then LV size, you can see that there's no ready tissue invasion into this. Then we know if there is some tissue invasion, then the next step when we resect the tumor, then we probably need to do a pericardiectomy together with tumor excision. And these echoes are basically demonstrated the compressed LV, the tumor mass is right there. But from the picture that we have seen, there was no tumor invasion. So we initially started with the top left, it's incision. So the retractor is facing, you can pretty much orientate the top end is the cranial end. And then we perform a median sternotomy to mobilize this mass in the mediastinum. And the second picture is the scissor dissection. And you can start seeing the third picture, you can start seeing that we're separating this mass from the mediastinum pleura because the pericardium was intact. And then subsequently the top right left picture, you can see the trapdoor incision, which is extension of a thoracotomy, which allow us to open up the chest like a book. And then you can see that the difficulty with tumor excision in this case is the mere size of it. So I will show you the true specimen once the tissue is out. And you can see that there's a lot of blood and there's cell saver. And then what happened is that we're trying to mobilize this mess. So while we're doing this mobilization, the most difficult part is to deliver this mess because of chronicity, there is a lot of fibrous tissue, there's a lot of adhesion, and as well as the limited access in terms of the chest. So once we manage to free the mediastinum, we begin to free this lesion from the lung, which is from the top part and as well as the bottom part. There is some adhesion to the lung, so which make us wonder, could this intrapulmonary origin or is this a mediastinum teratoma? So this is the mass size. This is about 20 centimeter by 15. And the specimen you can see, sometimes you wonder whether this is a child's teeth, but this is a calcification which looks like teeth material or tooth inside the mass. We submitted for histology, and histology shows surrounding lymph node. There are no bronchial opening to the mass, so this is most likely a mediastinum teratoma. Although my heading, and this is post-operative X-ray. Yes, post-operatively, because the lung adhesion, when they resected, there is lobar lung tissue, so he had 8 leaks for about 7 days. But I just saw him today. He put on weight, and he's doing well, and he's playing sports again. And this is a good outcome for this massive lesion that you don't really see much throughout the world. So I quickly do some literature review. Teratoma are benign germ cell tumors, most found in gonads, but it can arise from extra gonad site. The location is intracranial, cervical, pharyngeal. Intrathoracic is the component that we've seen. Mediastinum is common. Intrapulmonary is extremely rare. Now, I think the literature review that I've seen, out of studies, a lot of them are coming from Korea, but for the 10 years, they've probably seen about 36 cases or so. The other sites will be intra-abdominal and as well as sacrococcygeal region. Chu et al. Stated that mediastinum and intrapulmonary teratoma have a common genesis. Now, because they're so rare, so the pathogenesis or origin cannot really be determined. You can't do an elective study and say, these are the origins. So because they are so rare, there are a couple of hypotheses regarding how does it come about in the intrathoracic origin. So these are the few that I listed. It can originate from displaced thymic tissue from the third pharyngeal pouch. It can also suspect that this is aberrant thymic tissue. Some of the hypotheses say this is primordial teratoma focus in a potential mediastinum caught up in a respiratory growth. Hence, it actually landed in the lung. The other hypothesis is the primary pulmonary germ cell tumor represented an unusual differentiation of the somatic cell lines. And the last one is potential metastatic of the extrapulmonary germ cell tumor that landed there. So how do we differentiate between mediastinum and intrapulmonary? Because cases are so rare, but they found the common ground, which is direct bronchial communication, is the distinguished feature of intrapulmonary, which is reported in a half English literature and 2/3 in the Korean literature. Now, intrapulmonary teratoma predominantly located in the right upper lobe, which is 65%, and mostly in the anterior segment. Ours are different. Ours are in the left hemithorax, and it's based on the left lower part region, where the adhesion of the lung is. Likely to grow upwards and push the lung away and create an atelectasis. 2/3 occur in females. Intrapulmonary teratoma do not have any predilection for female. Most occur in the first and second decades of life, but age ranging from 10 to 58 in the literature. Now, the preoperative clinical diagnosis was difficult because it's so vague. If you look through cough, fever, chest pain, hemoptysis is 3 times more commonly with intraoperative finding of bronchial communication, loss of weight, pneumonia, bronchiectasis. Now, it's like trichophytis, right? So it's coughing out air, right? So it's most unusual, but really that's usually presented with a rupture into the bronchial communication. Radiological findings, chest X-ray, you will see in the early disease, you will probably suspect a pulmonary lobulated mass. Cavitated mass means it's ruptured and coughed out. Presented a pulmonary opacity or area of consolidation with a peripheral translucency, a cavity with a peripheral translucency as well as intrapulmonary calcification. It's a characteristic of intrapulmonary teratoma because the air communicates with the mass, basically. CT scan of thorax with your area of soft tissue, local fat content, punctate calcification, which is what we've seen, and then obviously very, very rarely that presented with ruptured teratoma, which you will see the irregular margin and the bursting configuration of the fat content. MRI is just another diagnostic procedure. Now, I put up the slides for us to think about. Generally, when you see opacity, the radiological features versus signs and symptoms, these are the 4 common: intrapulmonary teratoma, hydatidus, acute lung abscesses, chronic lung abscesses. These are radiographic features suggesting of what potentially could happen. Now, histological features basically it suggests that tissue originates from one of the 3 layers of germinal cells. 30% are immature type, which have a malignant potential, and tumor with a pancreatic tissue prone to rupture due to the enzymatic reactions because they erode into the surrounding tissue. And treatment is resection. So I would like to thank you for attending our first general club, and we'll take the question right at the end. But I need to acknowledge my senior surgeon, Dr. Sussman, and his team. They did a wonderful job on this patient, and the outcome was great. And without our senior support from Mopak, I believe that we can't achieve this greatness. So thank you very much for listening. Now, I would like to introduce our next speaker.
Questions now.
No. Should we take the question at the end?
Let's take questions now.
Okay, for those who are attending online, you can type your questions to the chat, and then we'll try to answer them. But I'll try to answer the local group. Any questions, guys?
Firstly, congratulations. I didn't think we were going to have a happy outcome when I first saw that, so well done. And I think credit must be given to you for realizing our limitations here, for seeking assistance. So well done.
Thank you. But I think it's a team effort, and then I think everybody put a lot into it.
There was a facility that was more experts in this.
Sure. Any other questions, Yashna? You okay? Trish? Yeah, Ashlyn?
So after this, they didn't require echo.
No.
Ventilator for
Patient was ventilated for 24 hours and extubated, and I was there in theater. So arrived in the morning, we got the case done. I catch 1:30 plane and back to Pietermaritzburg. So the good thing is that the lung actually, once the tumor or the mass has been excised, the lung actually aerated beautifully.
And usually with these patients, if they're younger, they tend to have like a hypoplastic lung. Because I remember in Bloom as well, we had a big case.
Sure.
I think a 28-year-old thing. I'm actually trying to scroll looking for the pictures. It's almost very similar to this patient. I remember the hemithorax was up to the front of the kidneys. So the diaphragm, that's how big it was. Do the shift and the same thing. We also prepared the femorals for possible bypass, and we resected it. The approach was a bit different than yours. We did fourth intercostal and seventh intercostal space, two for a cut.
Oh, sure.
And we managed to get it. But my colleague, Dr. Richard Schinenberg, he told me if you go for a mediastinal tumor that's quite large and it bleeds, go quick. And it's quicker, you get your hemostasis quicker. And he was very aggressive, and I was like, no, man, I can't. But I think experience plays a role, and immediately he opened 3 or 4 big pockets of cystic lesions, and when he sucked out the blood, the mediastinum and the pressures, and you can see the hemodynamics improved dramatically. And then slowly with the Laker show, we took out everything. And the recurrence here, I would say there is a possibility of recurrence with acute teratomas. So you try to really resect the whole capsule and try to have good margins if you can, because if you leave the capsule, they say there is a percentage of recurrence. And yeah, this is like one of the very rare. I think to me that case is exactly the same. I'm like amazing, and it's not.
I think as surgeon when they plan they trying to take it out. My comment because I think in the department when we facing this massive tumor, we always debating about the approach, surgical approach, what can give you the best access and protection. Now, when you see when a hemodynamic compromise, basically what he did is he debulked it, just like a massive hydatid cyst. If you can't get around the lung and do an enucleation, you ended up basically aspirate and then decompress the cyst, and then you have room to deal with it. I think that's the only limitation with thoracotomy. Whereas median sternotomy, you got access. If you really run into trouble, you cannulate, put on a bypass, decompress the heart, then you don't have to ventilate, but this lung is completely compressed anyway. This is purely just a mess with a limited space to take out the tumor as an unblock. And they did really well. They shouted out.
With that patient, I remember the lung was very hyperplastic actually. Well, I wouldn't call it hyper, but very small compared to the hemithorax size. And then she took around 3 weeks with a drain just to try to get the diaphragm back to the position to a point where you can take out the drain and happy with the outcome of the lung. But it was always looked like hyperplastic lung compared to the other lung.
We were quite lucky with this kid because, the lung aerated. But the other issue that we have with this as well is that when a tumor this big and a button mediastinum, is that the phrenic nerve preservation is one of the things that we want. And then constantly when they're dissecting the mediastinum, they were looking for phrenic nerve to preserve it because it's so easy to cut through it. And then next thing, you have a phrenic paralysis where the diaphragm comes all the way up and compress the lung anyway. But I think the post-operative X-ray shows that he's actually, it's intact. And then we were quite amazed about it because we cannot identify. And later on, when they truly found that the phrenic nerve was actually displaced inferiorly, quite far away from where we were dissecting, thinking there's where the phrenic normal position is. And you can see there are multiple clips there as well. Right, so once again, I think he did well. We're happy. And any more questions, guys? There's coronal and sagittal. You want to see a sagittal, coronal? Oh. Okay, there's Dr. Maraj. Welcome to the room for those Coxstead who's attending. Dr. Maraj is here. And then I'm just showing him CT scan again. No, it's all the way up. I'll show you the other one. There is there. Okay, swallow. Dr. Maharaj, any comment? Mature cystic teratoma, mediastinum, most likely origin.
No, well done. Research from both.
Yes, that. Thank you. Yeah, we acknowledge that. So, without further ado, I'd like to introduce my colleagues. Dr. Gounder is the specialized physicians in both Sanan and Mediclinic Hospital. We asked him recently, we do have a patient with a SLE and lung involvement. So he's going to give us a detailed talk about SLE and the lung. So let me just get his PowerPoint
What do I
ready
know
for
that everyone?
you.
Good evening, everyone.
Good evening.
Good evening, Dr. Miraj. Firstly, my presentation is not as fascinating as Dr. Chen's.
Just stop this quickly.
Yeah, so I'm going to be speaking a bit about SLE and the lung. I'm going to speak from the perspective of a general physician. I'm not a pulmonologist, and that's why I've asked Dr. Ram Kilawan, the pulmonologist, to comment. And it's a very simple, basic approach to SLE and the lung.
You click on it, it goes like, there's the bottom corner, there's oh, it's all white, so you can't see.
Okay, firstly, when I started reading 2 days ago, I discovered that the criteria for lupus have changed. My undergraduate and postgrad training, we learned that to diagnose lupus or SLE, you needed 4 out of 11 criteria. And now we've got new guidelines. So I just want to go through that first, making a diagnosis of lupus. So there's different domains. There's different domains that we use to make this diagnosis. This is the EULA and the American College of Rheumatology guidelines. Did you know about that, Dr. Miraj?
Yes, I had read this as well. I'm surprised you only read it 2 days ago.
So there's constitutional symptoms. So in summary, let me go to the next slide. You need 10 points and an ANF that's more than 1:80 or an equivalent positive test. What we mean by equivalent positive test, another autoantibody that's positive, which I'll go through a bit later. So 10 points, not hard to get 10 points. So constitutional symptoms of a fever is 2 points, alopecia 2 points, oral ulcers 2 points, discoid lupus itself 4, acute cutaneous lesions 6. Arthritis, I think this is important, that you need synovitis of 2 joints, tenderness of 2 joints, or early morning stiffness of more than 30 minutes. Early morning stiffness of more than 30 minutes is 6 points, which I thought was significant. Neurologically, delirium is 2, psychosis 3. If you have a seizure, allocate you 5 points. Serositis, a pleural or pericardial effusion, is 5 points. Acute pericarditis, 6 points. Hematologically, leukopenia, 3 points. Thrombocytopenia, 4 points. Autoimmune hemolysis, 4 points. Renal, proteinuria of more than 0.5 grams per 24 hours gives you 4 points. Class 2 or 5 lupus nephritis gives you 8 points. Class 3 or 4 lupus nephritis gives you 10 points, which basically means you have lupus. Antiphospholipid antibody. Sorry?
Cardio?
We did.
Good.
The acute pericarditis gives you 6 points, and the pericardial effusion 5 points.
That's all.
That's not
I had a guy that had the ANF was positive thyroid, and he had acute cardiogenic shock, and he had a myocarditis. So does he qualify as lupus?
Myocarditis was not part of the criteria.
No, but he had full-blown myocarditis.
But remember, now
Someone
you would have got 6 points for
Possible pericarditis.
pericarditis. You must have had a pleural effusion.
No, he had came in with,
And hematological, we must have made that.
no, he didn't have one.
No, then you didn't have criteria to say call that lupus.
But we call him lupus and he responded.
He responded to steroids. He didn't respond to lupus.
I'm not joking. And I read it up in the literature. I've got a whole article on it.
But it's
on
not
my
the
desk.
criteria.
And it's there. Lupus, myocarditis, and cardiogenic shock. I was going to write it up actually. There's only about 7 cases or something in the world.
Okay, any experience with this criteria?
The only thing in lupus that in the heart is usually the leg mat sac,
Yes.
endocarditis and the
very
But
Okay.
that doesn't meet the criteria. That's not
Yeah.
the criteria. But,
No,
I
but
know
there
a
is
pericardial
lupus
effusion.
myocarditis.
Not unless it evolved maybe from pericarditis and it evolved into myocarditis, full blown myocarditis.
No, but now he's talking about points. So that means they didn't fulfill the points that we had in this patient. I will pull out the notes, but I've read the articles on it and it's there.
Any other physicians?
It's documented.
I think he didn't go for the points, but there's a cross reaction.
No, he had lupus.
Autoimmunity and the
That
heart.
was lupus, no doubt.
Which
Well, he didn't meet the criteria.
Yeah, that's what I'm worried now. We were writing him up.
What's the treatment for myocarditis?
No, we just steroid him.
What's
We
the
didn't-
treatment for lupus?
Same thing, I know. We didn't plasmapherese him, but we steroid him. And he survived. He was on triple.
That doesn't mean he's got lupus. He could have responded from a viral myocarditis. I think that's why we have criteria like this. Otherwise, every myocarditis will be called lupus.
Then before the 2 days ago, how you were diagnosed?
Oh man, I knew this, but I didn't know the actual criteria. That I was still using the whole 4 of 11.
See, he fulfilled that one.
No, he didn't. No, myocarditis was actually part of that.
Exactly. Thank you very
Right.
much. I think you need to review the criteria of the cardiologist.
Okay. Mitesh, any thoughts? The cardiology, the myocarditis,
I mean, just Google it. It's there.
but you understand criteria as well.
I mean, this lupus for lupus is a big one.
Yeah.
So, really good.
Trisha, any thoughts?
Also, I think it is a criteria. And if there is something that may be suspicious, like the ANF is positive and all that, it might happen that maybe it's maybe cardiac manifestation, because lupus can present maybe with the system and all, although it's not part of the criteria. It some applies. I always say some applies even with kidney. It can present only with isolated, kidney involvement. So it might be
But it's
happening.
quite clear here with the kidney.
Yeah.
But it is an odd criteria.
Yeah.
You get 6 points for early morning stiffness,
Mm.
but if you have a seizure, you only get 5.
No, and
And
then
early
this
morning
vasculitis, you got.
No.
I didn't see vasculitis
Skin, just the skin there.
because I've seen lupus coronary involvement.
And the
No,
way-
because I was-
the way the criteria is now done, is do they say why it's maybe why they classify it like this now? It's not this way.
No, didn't go into that.
But a lot of the criteria is based on biopsy. It's difficult to do myocarditis. So it's difficult to prove that the amount is high.
This thing is really going to biopsy all this.
Yeah, but that's why Bino has the biggest criteria. You've got a biopsy diagnosis with 10 points.
But it's definitely in the literature. I can guarantee.
So I can just see in our British Society of Rheumatology, so lupus myocarditis, 5 to 10%.
Thank you very much.
presentation. And
No,
we
that's
got
not.
to
That's
consider
not. That's
very
not. That's
fatal.
not. Still not the
It's just saying that
criteria.
Not,
We're
That's
not
why
doubting.
I'm asking this.
We're not
Well, I
doubting
think-
lupus
I think this
myocarditis.
group, it's not probably from the criteria, but it is a complication of lupus.
Yes.
You can get
So it should be in there,
But all manifestations of
probably they are 5 to 10% of
which is still good.
complicated lupus.
Still high. That's 1 out of 10. Those are plain reviews.
But not all of the criteria is represented here. Because look at the respiratory criteria.
Yeah, that's what we're coming to.
It's all down, right? If you look at the respiratory criteria,
Where's the respiratory? Let's see.
No, we get into
Plural
that. That's
effusion.
the whole talk. We're
let's move on.
first establishing a diagnosis of
Let's
lupus.
move on.
No, I think this must be corrected. I think you should write a letter.
Can I leave that to you as a cardiologist?
Yes.
Okay, so
And even that 1 in 80, we never took that number there. We used to say,
obviously studies have been done.
I
I
know.
don't think people thumbs up this.
But you know the Rangasamy in the ward. He's 1 in 180. You
So
saw
I
him.
agree, but he doesn't meet the other
He
criteria.
does. He had chest pain. He had serositis
There's
type
no
of pain.
chest pain there.
No,
chest pain.
serositis. Remember I did the angio? You came and ordered all this. I saw the results today. So I told him, no, it's nothing.
Now, even if one is to 80, I wouldn't.
But he's got
say
serositis and he's got something else.
Let's
There's some
go.
other-
You see, your patient got serositis.
How many points? 10 points. There's a bit.
I mean, what's the serositis?
I know you got ANF of 1 in 80. That means he got lupus.
No, he's got. You said
He's
now
got serositis, plural, 5 points.
he's got a pleural effusion. No man.
Yes, that's what you did it, Rangasamy. Tall, big of, get 6.
Okay, so can we say that this criteria has limitations?
Thank you.
Okay. So the auto antibodies in lupus, I think we often order this and we don't really look at it properly. So the anti-nuclear antibody, 95% of patients with lupus will be positive. Double-strand DNA, 40 to 85%. Anti-Smith, 5 to 50%. Antihistone, which is usually positive in drug-induced lupus, 40 to 80%. Anti-Ro and anti-La, 15 to 40%. Always remember that anti-Ro is also positive in Sjogren's syndrome. Cardiolipin, lupus anticoagulant, 20 to 45%. And rheumatoid factor, I think that was interesting, 25% of patients with lupus will have a positive rheumatoid factor. Any thoughts? Okay. So the pathogenesis of lupus, Yeshna just reminded me that it's quite complex. But I think in simple terms, it's hyperreactivity of B lymphocytes, hypergammaglobulinemia, production of organ-specific, non-organ-specific antibodies, which results in the presence of circulating immune complexes. The T cell subsets are altered, and this results in increased phagocytes, which shows increased cytokines. So you basically start destroying your own cells. And this is not always organ-specific. I think that's important as well. So there's certain cytokines that target certain organs, and there's certain that target could be any organ. Okay, so I think this is the most important slide today, that pleuropulmonary lupus, that means the respiratory complications of lupus, there's 8 well-defined entities. I think this is what we need to look for. Number 1 is lupus pleuritis, which basically they describe as a pleurisy, which maybe Dr. Miraj's pleurisy is. Second is a pleural effusion, acute lupus pneumonitis, shrinkage lung syndrome, interstitial lung disease, diffuse alveolar hemorrhage, pulmonary arterial hypertension, and pulmonary embolism. Does anyone think we missed anything on this? Yeshna, anything?
There are other presentations, but I think
Right.
that so within the interstitial lung disease, there's several
Yeah, I'm going to go through that.
things. But like the diffuse alveolar hemorrhage is part of interstitial lung disease.
Mhm.
So, and the acute lupus pneumonitis is also part of interstitial lung disease. So, I think carry on. I don't think you missed anything, but carry on. Let's see how.
Okay. So, what lupus, I think that from my reading, what's coming out is that, lupus and a pleural effusion could mean several things. It doesn't mean the pleural effusion is from lupus. And when we see a pleural effusion in lupus, the aim is to rule out other causes, from non-benign to TB to parapneumonic. So the incidence of pleural involvement. So it's frequent, especially in men, and I think everyone should understand that lupus is much less common in men, but when it affects men, it's maybe 20 times more severe than in females. I think in our experience we know that. But pleural involvement is more frequent in men. Nearly 50% of all patients with lupus have lung involvement at some stage of their disease. 4 to 5% present with pulmonary disease. So what we mean by this is they have interstitial lung disease, we start looking for a cause, and we find they have lupus. Or they have a pleural effusion, we look for a cause and we find they have lupus. So commonest is pleural involvement. 45 to 60% of patients with lupus, of respiratory complications, is pleural involvement. Pleural effusion, pleural fibrosis is 50 to 93%. Incidence of parenchymal involvement, actual lung involvement. It could be acute or chronic. Acute lupus pneumonitis accounts for 2 to 9%. Out of all interstitial lung disease, 3 to 9% is usually undiagnosed lupus. Would you back that figure? Okay. So I think it's important when we see interstitial lung disease to continue as part of our workup looking for lupus. Diffuse alveolar hemorrhage is rare but critical. The mortality is 50 to 90%. I think we learned that the hard way. Global. So lots of studies were done in the eastern countries, Japan, even Pakistan, India. I think that's where the prevalence of lupus is highest. Out of interest, I think about 5 years ago, I had a young Pakistani man. He's been in South Africa for some time. He's probably about 32. He was not on a medical aid. 32, fit, healthy guy. But over the last few months, becoming depressed, went to a psychiatrist, started him on battery of medication. And he came in respiratory distress. He was found to have bilateral pleural effusions, pericardial effusion. And within 24 hours, he died. Fit man. He had like a kid that was 6 months old or so. And I was worried about autoimmune disease and stuff. And his ANF was 1:1,000 and some odd. His complement was in the booth. This man had lupus. And he had neuropsych manifestations that was missed. And he was going to King George Hospital. And
So why did that?
Sorry?
Why did he die?
Respiratory, cardiac.
Stress.
No, he had bilateral effusions and a huge pericardial
Couldn't
effusion.
drink.
Tubed him, ventilated him.
So the most likely thing
Came in
there
with
would have been your acute interstitial pneumonitis,
Yeah, probably.
which presents.
We didn't want a plasma fluoris.
No, it was too acute.
You can't.
Came in within 24 hours.
He showed us the way.
It would have been if we had the diagnosis.
On that note about men, that article that I read also confirmed that the cardiac myocarditis is prevalent, just like the lung.
Yeah. I've seen lots of men die from lupus.
But I read it a while ago.
Lots of men have died from lupus, I've seen.
Yeah, but it's devastating when they have.
Yeah. Renal involvement with lupus? The men. Do you see it?
And much more severe, much faster progressing, harder to bring into remission.
Okay, so investigations, chest X-ray is not useful with early lung involvements. Sensitivity for screening for lung involvement is low. Early detection, it's recommended to do a HRCT. HRCT findings, a thickened interlobular septa, 44%, parenchymal bands, 44%, subpleural bands, 21%, bronchiectasis, 21%, bronchial wall thickening, 21%. Fits in.
The percentages. But we see a lot of parenchymal bands, if I could just mention that.
Okay.
You know, we scan patients and then routinely you might find some parenchymal band as a random artifact that you don't know what to do with this information. The more scans you do, the higher incidence you're going to find some sort of an abnormality. And I think it's just important to realize that you need to screen those patients at least to a baseline ENF.
I didn't realize bronchiectasis was so prevalent.
Now, if you go back, I mean, HRCT is an expensive test. You can't HRCT everyone. So on a practical
Oh, if
basis,
someone has lung involved, but we
No,
come,
no,
we come to it.
what you
It's
gonna
part
do?
of, don't worry. That's what Yeshna, we call Yeshna.
A lung function
Yeah.
fusion scan. Can't you do that as a cheaper test before this?
So a study from China showed they took all their lupus patients and the ones with respiratory symptoms, and they did HRCTs. And ground glass opacities were found in 55.6% of the patients. They were mostly bilateral. And they also found that HRCT findings correlated with open lung biopsy findings. So 21% of patients with normal chest X-rays and normal lung function had diagnosed interstitial lung disease using HRCT.
So if you have a high index of suspicion, you can go to that, but
Yeah.
you can at least pick up abnormalities before that.
Therefore, abnormal HRC diagnosis of pulmonary involvement is not detected by other diagnostic.
I tend to agree that it's an expensive tool. You can't screen everyone with an HRCT.
No, I'm not saying screen. I'm saying if they have respiratory symptoms.
Yeah, if they have respiratory symptoms, then I think it's only fair to offer a CT scan.
Yes.
But it can't be used as a screening tool. So it's not every lupus that walks through the door that you should be doing an HRCT.
That's why your lung
So
function.
and your 6-minute
better.
walk test as well.
Yeah, but that's like subjective.
So this is what they've recommended in that. So diagnostic tool for patients with SLE and subclinical pulmonary disease. They recommended lung function, early detection of lung involvement because low diffusion lung capacity without clinical manifestations. Sometimes your imaging is normal. Limitations, I mean, they went into detail about this. Often, many of these patients have already obstructive, restrictive, or abnormal diffusion capacity. So, you know, they may have cardiac disease, COPD, so it makes it tough. 6-minute walk test, distance walked, oxygen saturation, and patient recovery. And I think maybe a 6-minute walk test and a lung function, and if that's a problem, then we proceed to HRCT.
I think coupled with the chest radiograph, those three modalities are sufficient.
But normally if you're seeing stuff on the chest X-ray, we're quite far off in the process. So diagnostic tools again, a chest X-ray, a CT, lung function, a bell, and biopsy. But take-home message was HRCT, lung function is sufficient. So just to go back to a bit of interstitial lung disease, which we are creating with our patients, and that's what brought about this discussion. It's 3 to 9%, non-specific interstitial pneumonia, organizing pneumonia, lymphocytic interstitial pneumonia, follicular bronchiolitis, nodular lymphoid hyperplasia, usual interstitial pneumonia. So I think this falls more into what you're talking about, Yeshna? This?
Yes, exactly. So there's more of an interstitial within the spectrum of interstitial lines.
Yeah.
There's several manifestations.
So they more put it under this. So most common is your non-specific interstitial pneumonia. Patients present with a non-productive cough, dyspnea, decreased exercise tolerance, and bibasal crepitations. So it's based on your clinical stuff that you order an HRCT and the diagnosis is made. You exclude infection, drug toxicity. I think drug toxicity is important. I mean, recently we've been seeing a lot of drugs cause interstitial lung disease, from amiodarone to macrodantin. And left ventricular failure as well, we obviously have to rule out. The serological markers do not correlate with interstitial lung disease from lupus. It's important to understand that. So you may have an ANF of 1:80, but you still could have interstitial lung disease. Treatment for interstitial lung disease is recommended that we achieve induction with corticosteroids or cyclophosphamide or MMF, and maintenance they have recommended azathioprine or MMF. Poor prognostic factors: patients who smoke, if they have a thrombocytopenia, or a degree of fibrosis on CT. So in conclusion, and my recommendations is chest X-ray, HRCT, lung function should be part of your diagnostic workup for lupus, but obviously we're taking out the HRCT. The HRCT, I think, is more in first world countries where they're doing it. That's their recommendation. But I think we'll stick to chest X-ray, lung function, 6-minute walk test as part of your respiratory workup for lupus. Doctors should be aware of the 8 respiratory manifestations, and we should have active surveillance of pulmonary complications of lupus.
So Devon, through your presentation, like say for example, patient is SLE, which is falling into the care of physician. How frequently are you, when you say active surveillance, how actively are you looking for the disease? Because a lot of time in our South African setting is a disease-specific treatment modality. Patient comes in who had cough, and I say, let's do an X-ray, let's do 6 minutes. There's pulmonary opacity. You're already down that stage. So in this document, do they recommend any regular surveillance?
Exactly. So that's the learning point to me. I mean, that's what I learned from this presentation, is that I think on diagnosis of lupus, that we have to do respiratory surveillance, irrespective. And then that's why I'm recommending a chest X-ray, a lung function, and a 6-minute walk test. That's what we start with.
Yeah, but
And if anything's abnormal, then we proceed to an HRCT.
And if the patient is symptomatic, go straight to HR.
Yeah.
But in terms of this follow-up time interval of surveillance, how I mean, 6
would
months,
I
a
would
year.
say 6 monthly basis when they see you. But see, they only reach Yeshna when they have. So she can't do surveillance.
But lung functions, I think every 6 months to a year.
Yeah.
But at least every year, minimum a year. That's what it should be. In a patient with lupus.
Your patient with a lupus.
So it's like how you would do proteinuria, for instance. You're just going to check, even if there's no impairment in a UNE, checking for proteinuria.
But I must say, part of the teaching, again, when I did my postgrad and undergraduate, respiratory, wasn't part of it. I learned, that's what I'm saying, I learned from this.
So it is not the commonest presentation of SLE.
It's not common, but it's there.
It is there. So if it's there, you can't ignore it. You have to have a high index of suspicion, as you say, high mortality and morbidity associated when it is present. But that's why I think that the teaching around it is poor, because it's not the first thing. People don't come in with the pulmonary complication as a primary presentation.
The part of the reason I'm asking that is that today I hope that we do have our colleagues from Coxstead hospitals, the GP run practices, and they take in this message home and say, you know what, they do have patient with SLE. How often should they do surveillance? When should they send the patient? Obviously, you don't want to send. You want them to send the patient when patient is huffing and puffing and almost dying. If there is a surveillance system where that is being set up, then a lot of disease, or as we'll say, screening or prevention is better than cure. Now, this part of this process is that allowing them to early identification, ring the alarm bells, and send the patients through. So it will come through the system, be managed according to the physician as well as respiratory physician. And that's basically ask that question. They will ask you how often should they do the X-ray. Now, I kind of agree, but also to disagree, because HRCT, yes, it is expensive cost, but compared to patient's life, you don't want to do HRCT when patient is huffing and puffing and say, oh, there's ground glass opacity, there's extensive fibrosis already, and it's almost like an end-stage lung disease that they're sending through. What must we do? So the screening tool, when you start in waiting, and I understand when you become symptomatic and you did it, then, but when you're symptomatic, a lot of time patients come in too late. When they are symptomatic, you do the HRCT. That's probably the
I
end of
disagree.
it.
I disagree.
You disagree?
I think, again, if you can do a simple chest X-ray, a lung function, and a 6-minute walk test, you would pick up most of the patients who are predisposed.
I think what is more important is, when you have this patient, you must have a baseline assessment, which means proper history taking, full clinical examination, and then this test. And then you review your patient, maybe 1-2 months, and then after you've done those, and then you see whether the patient is improving or is it getting worse. Then if the symptoms are getting worse, let's say shortness of breath, is coughing, dry cough, chest pains, and all that, then that's where you have the risk. But if your patient after 1 to 2 to 3 months, you say is actually getting better, I don't see the need for...
But if you're saying he's getting better, that means he has symptoms in the first place. Then you should have done the HRCT.
Yeah.
Yeah,
So can I say that maybe the context is also important because the GPs and the public that we are supporting from out of the city, you have to take into account how the patients present to them. What resources do they have in terms of X-ray reporting, good quality X-ray reporting? For example, there may be a number of X-rays that may report with the times in just even the reporting system like ours, right? They would take the pulmonologist to go herself and look at the X-ray to pick up some signs of lupus on the chest X-ray. So I think from their perspective, it's fair to say that if you have a patient with a positive serology for lupus and some respiratory symptoms, why shouldn't they ask for an HRCT?
I think
You would rather diagnose.
No, we agree. As long as you have respiratory symptoms, you should have an HRCT. There's no doubt about it. But the question is, we shouldn't be doing HRCT on all
basic
patients
traumatic patient.
on diagnosis.
Yeah.
Yes, that's the reason.
Another question too, like you're trying to screen for symptom, for early disease or respiratory disease for lupus. Now, what can change the management if you pick up an early disease? Do you have a modality of treatment that can actually, kind of put that on the baseline and it doesn't progress for years? Or whether we screen or not, and if it started, it's just going to continue? Because usually patients are on maintenance therapy.
Early treatment makes a difference. I mean,
Yeah,
I've
that's
had
right.
patients on Azapres for years that never progress.
But like for just necessarily, aren't they already on the treatment? Do you have extra treatment when you have a respiratory manifestation? Like,
Not necessarily extra, but you directed more towards stuff that's like, the Azapres, methotrexate is a possibility. You don't use methotrexate for,
I don't use methotrexate.
but it is one of the drugs that.
But it is enough.
Yes, I know it's there, but it causes pulmonary fibrosis. So, on one hand, it might cause suppression of disease. On the other hand, it might be the cause of pulmonary fibrosis. So, if possible, one would rather stay away from methotrexate because you don't want to have pulmonary fibrosis that's developing. I mean, you are abating the lupus. In the meantime, you're causing pulmonary fibrosis, drug-induced disease. So
we often see an overlap. I often see overlap of rheumatoid and lupus. So what drug would you choose for that?
So it depends to a large extent, right? So if you're talking about interstitial lung disease, that's what I assume you're talking about, right? If you're talking about an interstitial lung disease, then you really need to decide what type of interstitial lung disease this is. And there's two ways to do so. One is radiologically, and the other is with the biopsy. So if you go radiologically, you can You can try certain treatments, but of course, the best gold standard way would be to biopsy the patient. Oftentimes, it's difficult to biopsy a patient with connective tissue disease because they're unwell, they're sick. Patients with lupus are usually terribly immune suppressed. So you might have to go based on radiological presentation. Now, let's talk about the commonest type that there is on the interstitial lung disease, right? So that's an NSIP. So NSIP there's two types of NSIP. You get a cellular type and you get a fibrotic type. So you've got to decide on CT scan, is this too advanced? Is it fibrosis? Or is it still within a cellular spectrum? If it is, you immune suppress the patient. Prednisone, you give them some azathioprine. And if you need to go for a stronger agent, then you're looking at things like MMF or cyclophosphamide, or as add-on treatments. Okay. If the patient has fibrosis, then that is long gone. Right? However, I must tell you there are antifibrotics around. So if you have a patient with fibrosis, long-standing fibrosis, we can get antibiotics. That is an option. So it really depends. If you're able to detect this early, upfront, the prognosis of the patient is good because you are abating the fibrotic NSIP. You're just in a state of inflammation, right? So you can abate quite a lot in that way. But you got to be very guarded with the drugs. As I say, I don't use methotrexate commonly. If it was a rheumatoid presents in a different way. Rheumatoid, the commonest presentation of an interstitial lung disease is a UIP, which is a fibrosis already. So that patient might already have fibrosis. So one would wonder now, should you stop methotrexate because it's a UIP with fibrosis from that state, and you've really got to balance that act, of whether there's active disease like an NSIP, or if it's just pure fibrosis long gone. If it's fibrosis, then stopping methotrexate might make the joints worse. So you really got to have a calculated decision, I would say, in a rheumatoid.
Yeah, Shana, I've got another question for you. So we deviated a little bit to rheumatoid, but coming back down to SLE and lung. So important thing is that what do you think that when you see a chest radiograph that will alarm you to do a HRCT if patient is well?
On an SLE patient.
Correct.
So
We're
it's
talking about SLE and lung today, aren't we?
yeah. So it's as Dr. Gounder said. So he went through the presentation, right? So if you get pleural disease, so pleural disease means
But
that
we in South Africa that's prevalent. So, but we're talking about subset of SLE basically. Yeah. Okay.
So if you get a pleural reaction, where you're seeing pleural irritation, pleural thickening on the X-ray, if you see a pleural effusion, tap the effusion, find out whether it's an exudate or a transudate. Look for other causes. If there's no other cause, then you're possibly dealing with an SLE. If on the X-ray you're seeing, so what you're looking for is opacification in the mid to lower zones. That's where the disease usually will present. And it's almost like a ground glass. It's a wrong term to use with an X-ray, but it's almost like a ground glass where it's just a hazy reticular opacification. Yeah, that's all I would say. So that's what you need.
But I mean, even if a patient has lupus and has a effusion, you're going to have to do a CT.
Yeah, so
There's no-
any of those.
Okay. Right. I think we did fairly well with time. We're going to close up now. I just wanted to ask the online attendees that are there any questions that anyone would like to ask? You can, I think, unmute yourself. So if there's no further questions, I would like to close our first sessions or first journal club of the year. Continuously that we would like to send out the invitation to everybody, and we will invite different speciality to present the relevant topics, and hopefully that we can grow strength from strength. Thank you very much for attending, and good night.